we're going to start talking about basal ganglia disorders, and they're going to be classified as either hypokinetic, so less movement, or hyperkinetic, more movement. So it's either too little movement or excessive movement, because we know the basal ganglia either inhibit or disinhibit movement. So Parkinson's disease is the most common basal ganglia motor disorder. And even though it's classified as a motor disorder, it is also, the non-motor functions are affected as well. So there's a sensory, cognitive, and motor aspect of Parkinson's disease. But the motor aspect is those are the symptoms that send people in to get diagnosed. The dysfunction in Parkinson's disease interferes with both voluntary and automatic movements. And usually there are two common subtypes: postural instability, gait difficulty, known as akinetic or rigid type, or tremor-dominant. The akinetic rigid type is far more common, or it's more common. Tremor-dominant is, so it's 50% for akinetic, 40% for tremor-dominant, and 10% for mixed, meaning yay, you get both. So not fair, but there you go. The people that I work with in LSVT Big are largely the akinetic type, but I have had some tremor-dominant type people as well as people with Parkinson-Plus Syndromes, which we'll talk about in a couple minutes. So the akinetic subtype of Parkinson's disease is characterized by muscular rigidity, drooping posture, rhythmic muscular tremors, and a mask-like facial expression. People are getting diagnosed earlier and earlier with Parkinson's, so a lot of the people with early Parkinson's do not have the mask-like expression yet, or maybe they don't have it all the time. You can think of, with this type of Parkinson's, you can think of the cardinal symptoms, even though these aren't the only symptoms, as TRAP, T-R-A-P, tremor, rigidity, akinesia, and postural instability. So the TRAP symptoms. People with akinetic Parkinson's have difficulty coming to standing from sitting. Their gait is characterized by a flexed posture, shuffling of feet, and a decreased or absent arm swing. A lot of times, before they've even gotten to the shuffling part, they have that decreased and absent arm swing. So distinctive signs of akinetic Parkinson's include that akinesia, hypokinesia, bradykinesia, all different ways of saying the same thing. Either slow movements or smaller, slower movements, basically. Rigidity. A lot of times they have cogwheel or lead pipe rigidity, where you try to straighten out their arm and it's ratchets, sort of, or it's just solidly rigid. Postural unsteadiness, resting tremor, freezing during movements, which tends to occur a little bit later stages. Visual perceptual impairments, and that's that sensory mismatch. Mask-like facial expression, and that's that emotional loop part. And non-motor signs, a huge list of non-motor signs, largely affecting the autonomic nervous system. But so you can imagine, knowing all the things the autonomic nervous system does, what kind of symptoms might be involved. People with akinetic Parkinson's frequently have one hyperkinetic sign, and that's that resting tremor. And that is the thing that most people go into the doctor for, because it disrupts their function. And usually people with Parkinson's have, they start out with the tremor on one side, and then when they progress to advanced stages, it might be bilateral. People with akinetic Parkinson's, especially in the later stages, often have those freezing episodes when their movement abruptly ceases, despite their intention to the contrary. And it's known as fog, freezing of gait. And it's really frustrating for people. It's stressful and it's frustrating. And we have a couple different strategies that we use to deal with freezing of gait. It has to do with muscle tone. They don't know specifically what causes the freezing, but it is very frustrating for people. Tremor-Dominant Parkinson's disease, people experience both resting and action tremors. With the akinetic Parkinson's, it tends to be just a resting tremor. Rigidity and slowing of movement are relatively mild, but people with tremor-dominant PD experience a slower progression of signs and symptoms than those with akinetic PD. Sometimes people who are diagnosed with Parkinson's young tend to be tremor-dominant. I don't know why. The pathology in Parkinson's is the death of dopamine-producing cells in the substantia nigra pars compacta and acetylcholine-producing cells in the pedunculopontine nucleus. There is an interaction between dopamine and acetylcholine in the basal ganglia that gets off balance in Parkinson's as well. The cell death occurs long before clinical signs of Parkinson's become evident. So if a person has Parkinson's, their cells are probably dying off for 30 to 40 years before they start to actually have signs that they notice, which is really interesting. So the treatments for Parkinson's, there are medications that are initially effective. They have some side effects. The most common one used replace dopamine. They're dopamine agonists, meaning they bind to dopamine receptors. Carbidopa levodopa is the drug name. Sinemet is the trade name for that. A lot of times, good response to Sinemet is a diagnostic for having idiopathic or classic Parkinson's. Over the long term, the Sinemet can have some really unpleasant side effects like hallucinations, delusions, psychosis, and dyskinesia, which is unwanted movements. And the progression of the disease with involvement of other cells and neurotransmitters limit effectiveness. But people can have good effects with Sinemet for years before they start having these side effects. There are some invasive procedures such as deep brain stimulation and some destructive surgeries. There's just now experimentation going on with stem cells. I know of one person personally who had stem cell treatments that didn't last. As of last November, researchers at Kyoto University in Japan successfully transplanted neurostem cells directly into the brain of a patient with Parkinson's, and he's being followed closely, so I'm dying to know what those results come out. But with deep brain stimulation, people usually have good motor results, but then they have problems with other areas. People with DBS tend to have more problems with dyskinesias, and they have a lot of swallowing problems later on. So they tend to have more swallowing problems than people who didn't get deep brain stimulation. So it's not a fix. It's just another possible treatment. Rehabilitation is a good treatment for Parkinson's. PT and OT for improving mobility and functional status in individuals with PT. Intense resistance training produces greater muscle hypertrophy and functional gains. It used to be that they would recommend that people with Parkinson's not exercise very hard and everything, but now the current treatment is you need to exercise hard if you have Parkinson's. You need to push yourself. So there's several different programs. There's one that's called Pedaling for Parkinson's. The YMCA in Bellingham here runs a Pedaling for Parkinson's program at all their locations in Whatcom County, and it's very popular with a lot of my Parkinson's patients. It's it's a spinning class basically, at high level spinning class for people with Parkinson's. And there's a boxing program that's called Rock Steady Boxing that is specifically for people with Parkinson's, and it's boxing. You either use someone holding hand targets or a heavy bag or something like that to do boxing, so that big effort, forced movement. There's another program that's called POWER, and it's PWR, Parkinson's Wellness Recovery, that emphasizes resisted movements, resistance training, explosive movements, balance training. It's a really good comprehensive program. Another one is the one that I do. It's called LSVT Big. There's also a voice program that's called LSVT Loud. And the speech therapists at our clinic do LSVT Loud, and then we do LSVT Big in PT. Right now, we started out with 2 of us, one PT and myself, certified LSVT Big therapists, and now we have 3 PTs and 2 PTAs doing it, and it's great. So really, since 2014, I've seen almost 200 people with Parkinson's through the LSVT Big program, and it's a large amplitude movement training. It focuses on effort and amplitude of movement, and it's really fun. I love doing it. You see amazing results in the people that you're working with, and if you're interested in doing it, it's a super fun program. So Parkinson's plus syndromes are other disorders with signs that mimic Parkinson's, but they have to be distinguished from true idiopathic Parkinson's. So true idiopathic Parkinson's is that dopamine, the death of the dopaminergic cells. These Parkinson's plus syndromes are caused by other things. So we'll talk about a couple of them. Red flags indicating a different diagnosis include early postural unsteadiness. There's one of them that's called progressive supranuclear palsy, or PSP, and people have extreme unsteadiness when big falls early on. Later on, it sort of calms down a little bit on the unsteadiness, but it doesn't have a good prognosis. There's a rapid progression of signs leading to respiratory dysfunction, abnormal postures, uncontrollable and inappropriate laughter or crying, and signs of cerebellar, corticospinal, or voluntary gaze dysfunction. With PSP in particular, they have what's called, sometimes called doll's eyes, where if someone lies down, their eyes close, like those old-fashioned baby dolls, and difficulty maintaining an upward gaze. That particular dysfunction can be really difficult for the person and their family because you can't look someone in the eye when you have that voluntary gaze dysfunction. So Parkinson's plus syndromes are primary neurodegenerative diseases that cause signs similar to PD. Usually the cause is idiopathic or genetic. Syndromes that are included in this include progressive supranuclear palsy, PSP, Lewy body dementia, and multiple system atrophy. There's also cortical brain dysfunction that is classified as a Parkinson's plus syndrome. And I've worked with people with PSP, Lewy body dementia, and multiple system atrophy. And it's similar to Parkinson's, but it does progress a lot faster, and it's not a good prognosis. You can live with Parkinson's for many, many years, and you can get good results from therapy. People with PSP and Lewy body dementia and MSA do not get the same good results. There are also no drugs to treat any of these. One of the ways that sometimes they diagnose these, someone gets diagnosed like, oh, well, they probably have Parkinson's. They put them on Sinemet or one of the other Parkinson's drugs, and it doesn't work. So that's almost an indicator that it's one of these other syndromes. So PSP, it's characterized by that early onset of gait instability with a tendency to fall backwards, axial rigidity, which is also common in idiopathic Parkinson's, freezing of gait, depression, psychosis, rage attacks, and that supranuclear gaze palsy, that doll's eyes thing that I was talking about. Lewy body dementia causes early generalized cognitive decline, visual hallucination, and that Parkinson's-like movement. One of my current patients with Lewy body dementia, he said his first symptom was that he didn't recognize his wife. He says, okay, there's somebody in the house and I don't know who it is. and he'd see her and he didn't recognize her, and he said that was absolutely terrifying. So he's struggling with, he comes in for therapy and we're working on different things, but I've definitely seen a decline, and it's challenging for him. A multiple system atrophy is a progressive degenerative disease affecting the basal ganglia, cerebellar, and autonomic systems, the peripheral nervous system, and the cerebral cortex. So multiple system atrophy. With PSP and multiple system atrophy, both of them, rather than being dopaminergic cell problems, they are breakdown of the tau proteins in the brain, which are structural proteins in the brain. So that's one of the reasons why they progress so quickly, and one of the reasons why the symptoms are so widespread. Parkinsonism is different from Parkinson-Plus syndromes, and it encompasses disorders with signs that mimic Parkinson's, but the cause is toxic, infectious, or traumatic. It's often a side effect of drugs that treat psychosis or digestive problems. So drug-induced Parkinsonism frequently leads to misdiagnosis and unnecessary treatment for Parkinson's in older adults. So they don't really have Parkinson's. They really shouldn't be treated with Parkinson's drugs, but the effects seem like Parkinson's. Signs include subacute bilateral onset with rapid progression. So that's unlike idiopathic Parkinson's, which has unilateral onset and a slow progression. Early postural tremor and involuntary movements of the face and mouth. In the next section, we will talk about hyperkinetic disorders, which is sort of the opposite end of the spectrum.